All right, kicking on over and keep going on with burns. All right, we're going to talk about burns, chemical burns, the eyes and the skin, electrical burns. So you can be burned by electricity. If you don't believe me, take a penny and stick it in a socket and see what happens. You can be burned. We'll talk and go more in depth with that, but basically, electricity will usually flow through the body. It's looking to go to ground. So it'll typically look to go in where you're standing, if at all possible, or something that is close or closer to the body that goes to ground. That's easier to go than you. So it may pop out at your ankle and hit some sort of metal. But usually you have 2 points. You have an entrance and an exit point, and then you have the path of travel. We'll talk about that more when we get into it. Chemical burns has to do with some sort of chemical on the skin, sometimes in the eyes, in the mouth. That does happen. You can accidentally ingest a chemical if it got in your mouth and you swallowed it. Really what we're talking about, though, usually typically is the chemical on the skin and how to treat it, or in the eyes. Thermal burns are exactly that. That's just usually a hot object touching your skin somehow, some way. And then there's radiation. It can be from a radiologic entity with the alpha, beta, and gamma rays, or it could actually just be like the sun. The sun is radiant heat. And you're actually getting the UV radiation, and getting a sunburn is typically what we think about when we do radiation. And you can actually get second-degree burns from the sun, which we'll talk about that here in a minute if you don't know what I'm talking about. Talked about the types of burns. There could be systemic injuries overall, meaning that the overall body can have damages. We'll talk about what that is. Really, honestly, what we're really looking for is fluid shifting, and we'll talk about that when we get into it. The first thing that we're going to talk about, it looks like we're going right into fluid shifting. It's going to be hypovolemia. And what we're talking about is the fact that if you have a burn that's significant enough, typically it's going to be a third-degree burn, or I learned them in degrees, but really they're going to be a full-thickness burn, or it can be a partial thickness burn over a very large, massive area. You're going to start having the skin, and this is going to be really, it's eschar. It's probably going to be a third-degree burn or a full-thickness burn. The eschar is made. I don't know if you ever burned yourself and just noticed that you've got like a scab. Like I burned my finger before, and it kind of blistered up, and then it formed this nice like leathery skin scab. And it then eventually it came to the surface as the skin grew back, and then it just flaked right off and all done. If you do get this eschar, and it's kind of like compartment syndrome, if the damage is done circumferential enough around the extremity, and again, it can be to the torso too. It could be that you've got the eschar it's so thick and tight that it can't allow you to breathe and your chest to expand, or for blood flow to get through, and you're losing distal perfusion. They can do something called an escharotomy. Escharotomy is horrible. They actually have to go in and cut. They've got to make cuts and incision through that eschar, so the skin can expand. Remember, like part of the healing process for the body is to send fluid and to swell. Well, that's part of what's happening here. So what they have to do to combat that is to keep perfusion until the swelling goes down, is to actually make incisions and cut. They do talk about clotting disorders. You can either clot more easily and form an emboli, or fail to clot due to excessive bleeding. I do know that if you do burn, there's a chance that you could have blood loss. So with that being said, that you may actually lose some of your clotting factors, but that's usually really in trauma. And I know this burns are kind of part of trauma, but I really am more worried about people losing blood or excessive bleeding and failing to lose their clotting factors. So it is potential in bleed and burns. I'm more worried about the fact that you have fluid shifting, making it harder to form clots. That's what I would be more worried about. But if they do lose that, and you could have an emboli form and and shift, or a thrombus form and have it thrown into circulation. You can have a PE, you can have a thrombotic stroke or something like that. So I don't understand that too much, but that's my guess on what they're trying to say. Hypovolemic shock is big, especially the bigger the burn, the more area it covers over the body, known as body surface area, the worse the hypovolemia can and will become. And it's not, the fluid loss is not immediate. That's the thing about it. It's usually within the first 24 to 48 hours. So what you do in your ambulance matters, believe it or not. How you wrap it with sterile dressings. Burns are extremely painful. I've had burn patients where I've given them lots and lots of pain medicines and it barely touched their pain. But I've had some that I've given just a little bit to and it just made them very comfortable. But with that being said, though, sometimes you just cannot get their pain under control because it is extremely painful to have a burn. And especially the larger the burn, the worse it is. So what you're really worried about, though, is fluid shifting. And where fluid shifts in, and remember, we talked about this in the healing process, is you've got fluid shifting. Fluid will shift into, you've got intercellular space, which is the fluid inside the cells. The intervascular space is where you have like the plasma that is part of the blood in the vasculature. But where it'll go is it'll actually kind of go in and out and around in the area that is between the vascular space and the cells. It's called the interstitial space. And what happens is that you have the capillary permeability because they're trying to do swelling, trying to get white blood cells to come and start the healing process. But if it's on a large scale, you can indeed shift a ton of fluid to the third space, it's called third spacing, and have it shift and lose a ton of fluid to your vascular system, making you hypovolemic just because you've burned a significant amount of the body, or the percentage of the body, or the burn surface area is very big. So that's what it is. It's called third spacing. And it's basically, the fluid is non-functional. It has to do with the capillary permeability to let white blood cells out of the vasculature to try to start repairing the actual cells themselves and do a lot of the cleanup work. It's pretty bad. This is the same patient. I know that's hard to believe because it looks like a Buddha over here and like just a heavyset dude over there, but that's how much swelling could be there. So the problem with that is you start taking out fluid, just like in any hypovolemic shock, you got your less cardiac output, meaning there's not enough actual fluid to pump. You're not bleeding out. So what you're doing is you're taking, and it's kind of like you're boiling down the actual makeup. So now that you don't have all the plasma, now you're like trying to pump. Your heart is trying to pump cement, really thick cement instead of blood, and you're still hypotensive because you've lost the volume. So therefore, you're not perfusing well to the other areas. You need to maintain a certain blood pressure to perfuse everywhere, and you're not perfusing well. So now you're technically in shock, and that's called third spacing. There's some complications with burn. With the third spacing, with the third spacing, you have hypovolemia and shock. You are at risk for infection because the skin is, again, the big dog that protects us from foreign invaders. Once that's gone, it's game on. And so how quickly you sterile dress everything and keep them sterile doesn't mean they can't pick up something in the hospital. It does happen. But another thing is hypothermia. The skin helps regulate temperature. With enough amount of skin gone, technically, they're not going to be able to regulate their temperature. They will actually become very cold. Depending on where the burn is, if it's up in the airway, they could have inhaled superheated gases or smoke, and they started causing swelling to the actual airway itself, so their airway might be closing off, or they've got enough soot and smoke, or they've got an eschar around and swelling in and around the actual torso part of their body, that they actually might have soot and smoke, so it's blocking actual gas, oxygen, and CO2 exchange in the alveoli, or they actually have enough damage on the actual torso of the outside of the torso so they can't take in deep enough breaths, so they're not breathing properly, or there's enough swelling inside the airway that they can't get oxygen down and in, or they have compartment syndrome. Remember, we just talked about compartment syndrome, where there's an intense damage done to a certain area and swelling is occluding distal perfusion, and they usually have to wind up doing some sort of fasciotomy to open that back up to get that swelling down, or until the swelling goes down to allow perfusion distally. So burns are a big deal, huge deal. That's why I really decided to do them separately. So not only do you have how much of the area that they burned, what they burned, and the risk factors that are there, but we have to start thinking about the actual degree of the burn. I learned them as degrees, first, second, third, and there was a fourth degree, because you can burn into the muscle and bone if it's bad enough. But they actually renamed them now. They are superficial, which is the first degree burn, partial thickness burn, which is a second degree burn, and a full thickness burn. They give examples here. So a partial thickness burn is simply a sunburn. That is just basically like a sunburn. So there's just basically redness to the area that's affected. Obviously, this is a radiation burn. They've been outside all day, and you can see the tan line of what color their skin used to be. Now it's really red, so it's really bad. This looks like it's some sort of to the front torso. This is a second degree burn. Those yellow things are actually blister pockets. Do not pop blister pockets. See down here, blister pockets. Do not pop them. Do not try to alleviate those blisters and stuff like that. Don't touch those. Try to dress and do a sterile dressing and dress that in place, if at all possible, or cover with a sheet, because again, remember, they won't be able to thermoregulate with damage to the skin. So that's a second degree burn or a partial thickness burn. This is a third degree burn, also known as a full thickness burn. With a superficial first degree burn, it's usually just the actual epidermis. The partial thickness or second degree burn, where you have the blistering, it did get into the dermis. Full thickness means it went all the way. It's down into the subcutaneous tissues. So that means it's a severe enough burn that it burnt all the way to the fat layer of the actual skin itself. You can have this eschar looking skin. I know it's kind of tough to see here, but right there, that's kind of normal pink skin. So it looks like it came from the back part of the leg. But right down in here, this is what they call white and waxen skin, like a white and waxy skin. Believe it or not, this area right here is actually not in any pain, because it's burned all the way down to the nerve endings. So that's kind of the benefit of having not benefit, but it's not going to hurt as much as it normally would. This person and this person are probably in severe amount of pain because it didn't get all the way through. So the nerve endings are still there and picking up pain. This person probably has severe pain in and around the area of the burn, but not to the actual burn itself, because it's burned through there. Now, that does not mean they're out of the woods. They are actually going to have a more significant and horrible recovery. To actually have this skin, they're going to have to debride this skin, which basically means scrape it off and expose it all and try to see if they can actually do skin grafts from another area and put more skin on. It's actually horrible. But as far as pain management goes, these will be the patients that, and it should be a cause for concern. If you're like, hey, you're not in a lot of pain, because these people are going to be in a lot of pain, especially this person with a second degree or partial thickness burn. This person will not. So that's going to be your clue and tie in how bad it actually is. So the telltale signs: redness, superficial first degree burn. Blistering is going to tell you that's a partial thickness burn. White and waxen or charred burned skin doesn't exhibit a lot of pain. These people will be in pain. Not a lot of pain here. That's going to be your full thickness or third degree burn. Burn zone. So you actually kind of have a bullseye pattern, and it's not really a bullseye pattern, but it's going to be the area affected and how it's surrounded. So usually if you do have a second degree burn or a third degree burn, there's going to be the burn itself, and then you'll kind of see this is the second degree area of burns and right here, but it looks like right down in here there's not a lot of blistering. So that means that's probably more of along the lines of a superficial burn. So or it's all just second degree burn to that area and it stops because it looks like there's a line of demarcation there. But being said, it can be that these are the areas of he got burned up in here in this area, and down in here is just kind of a first degree or partial or partial Superficial burn, this is a partial thickness burn, so it's kind of like a bullseye effect. So this is the area that's worse, this area is not so bad. Same here. It looks like this area right in here is going to be the actual charred area where it's 3rd-degree burn. It looks like this is still white and waxing, so it'll be there. But as you look over here, this is kind of normal skin, so it kind of like transitions back. Sometimes it's a little more prominent. So they call them different zones. Zone of coagulation, where the actual burn has occurred. Zone of stasis and zone of hyperemia. It just has to do with the zones of where the damage is and how bad the damage is. So it all just depends on how long the burn was exposed to, the actual area overall that the burn was exposed to, timing, how long time the burn was exposed to, those types of things. There we go. So the depth of the burn, the extent of the burn, the critical areas involved, ages you do want to be concerned with, younger than 5, over the age of 55, pre-existing medical conditions, those will factor in for burn severity. So how do you calculate the burn surface area? So you've got the burn, you figured out what type it is, and you kind of have the area of your I call it the bullseye effect. You kind of got your area of where this is bad, this is not too bad, this is normal skin. So what you're trying to do is try to figure out the actual burn area. So they use the rule of 9s, and you kind of have to memorize the rule of 9s. It's into 11 sections, and it's either like the front torso is 18%, or excuse me, the front part of the actual core of the body is 18%, which means that the front torso is 9, the front abdomen is 9, the back is 9, so the back is 18, so the top half of the thoracic spine is 9. So it's all divided, and I've got a picture for you to see. Or you can use the rule of palms, where you take your palm, this is 1% right here. This right here is 1. And you can actually take the palm and go, okay, 1, and it has to be their size, can't be your size, it has to be their size. So you may have to guess that your hand might be 1.5 times their size. So you're like, all right, 1.5, 3, 4.5, 5. So you can kind of estimate that way. This is your rule of 9s. It does change for pediatrics, so keep that in mind. Usually the leg is 18. For pediatrics, it's 13, or infants is 13.5, 16.5, and the head is different too, because the heads are bigger in infants and pediatrics. So as they go through their growing stages, that's what it is. But that's the rule of 9s. There's also the backside as well. So assessment of your burn patient. Seeing signs up. You want to know mechanism of injury. What caused the burn? How did they get burned? Also, if it's safe for you to approach, because if something burns someone, you might be stepping into a hazardous situation. Make sure you don't have any environmental hazards. Consider your C-spine. If they didn't fall, you may not have to consider it. Or if they didn't wind up having a cervical spine injury either. Rapid body scan, the thing that you want to look for initially is you want to try to stop the burning sensation. If you can stop the burning. If it's a thermal burn, usually the ones that we run are people standing around a fire pit and they wind up tripping and falling into a fire pit. If they're still actively burning, find some water, do something to get the burning to stop. Even in your chemical burns, hopefully they know on scene how the chemical works and what it reacts with, and if you can use water, or if you have to brush it off, or what you have to do to go ahead and clean them. Also, with that being said, don't burn yourself. You need to maintain safety. You need to be very, very cognizant of, if you're trying to brush off this chemical, that you're not brushing it on, you're kneeled down next to him, you're not brushing it onto your knee, which gets on your clothes, and then later you go and you just kind of swipe your pants off at the knee level, and there you are, you've got it on your hands, and it's actively burning you. So be very careful. Sometimes you may have to take an extra minute to get into a Tyvek suit or some sort of protective clothing. One of the things for burns, again, we go back to burns now, is airway involvement. Make sure it wasn't done because of abuse. Someone actually tried to set someone on fire. That does happen. Do your ABC, DE, DCAT, BTLS. You want to kind of associate the type of burns, the redness, swelling, the blistering, if there's charring, how much pain they're in. Do a sample history. Look, make sure you, again, airway involvement, airway involvement, airway involvement. Look for like soot in and around the mouth to see if they actually were breathing in the smoke, like especially if someone was in a fire and they're brought out by the fire department. Singed nasal hairs, that'll tell you. Try to figure out the type of burn or the classification of burn, whether it's a superficial, partial thickness, full thickness burn. Rule of nines to figure out how much of the actual burn percentage area is been done. And then do your DCAT BTLS. Try to remove the burn clothing. Sometimes the clothing, if it's made of like some sort of tech material, like it's not cotton based, it's like a poly fiber or something like that, like Under Armour, or like some sort of plasticky like tech pants, like a jogging suit of some sort, and it winds up actually, it can melt to the skin. It's not your job to try to pick that off. Your job is to actively stop the active burn. You may have to just dress it in place with it actually still burned and attached to the skin. I know that sounds horrible, but that's the reality of it. Your job is not to pick that off. Your job is to make sure that the burning is stopped and not causing any more damage. And you make sure that they're dressed. They got sterile dressing in and around the burns as much as possible, and to make sure they're thermoregulated and to watch for third spacing. Listen to breath sounds. If you can get an oxygen saturation, put them on oxygen if they need it. Check their neurologic baseline. Make sure they're still mentating well. That way, if anything changes, you'll know. Your primary survey, get your vital signs. Try to get a description of what happened, what was involved, the areas of involvement as far as the location on the body. Reevaluate your interventions and treatments. Here we go. Stop the burning process. That's what your goals are. Stop the burning process. Assess and treat their airway and their breathing. Support circulation and do rapid transport. And if you're an ALS unit, try to do pain management. All right. So we talked about third spacing and how it affects the patient. And they're saying in here to do aggressive fluid resuscitation and general wound care. Yes, absolutely. Do a sterile dressing with sterile bandaging. And you're probably going to have to do some pain management if you have an ALS truck and IV fluids. But let's talk about that. Let's talk about fluids here. You can fluid overload a burn patient. There is something called the Parkland burn formula. Hint, 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 nudge, 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 wink, wink, wink. This is freaking important. Parkland burn formula. You need to memorize this. The reason why finding the body surface area percentage of a burned patient is so critical is because it is part of your fluid resuscitation. This patient is going to third space no matter what. Like, it's going to happen. So your goal is to try to just get on enough fluids to keep that, even though the third spacing is going to happen, and you're like anywhere between 10, 15, 20 minutes of care to an hour to 2 hours of care, is to getting them to a burn center because that's where they need to go. That's the most appropriate facility. I know for where I'm at, the closest burn center is either Augusta for the Medical Center of Georgia, which is the burn center in Augusta. We've got one in Wellstar, Cobb County, which might be closest for you guys, and Grady is a burn center. So with that being said, they need to get to a burn center. It's 4 milliliters of normal saline or lactated ringers times the body surface area percentage burned. So if it's 50%, it's 50. There's no decimal point. It's just 50 times the weight in kilograms. How you find weight in kilograms is you take their pounds, divide by 2, and then knock off 10%. So if I weigh 220 pounds, divide that by 2, it's 110. Take off 10%, it's about 11. So I'm roughly around 100 kilograms. And then you divide all of this by 2. The first half is to be given in 8 hours. So then you take whatever that is, the division by 2, divided by 8, and that's how many milliliters an hour you're supposed to give. The other is supposed to be done in 16 hours. Your goal really is just to set this up and have this kind of just going at that rate. So when you transfer care, it's already done, and then usually the burn units will take over and figure out how to control the fluids. But that is the Parkland burn formula, and that is very essential. All right, so types of burns. We talked about thermal burns. It's usually often deep. There's different types of thermal burns. There's the scald injuries, which is hot liquids. You've got a contact burn, which is the direct contact. Steam burns, you can get steam burns. If you've ever been a fireman, you've been steamed before. It's not fun. Flash burns, usually from explosion or flashover for firefighters. Like if you've ever like put a bunch of like lighter fluid or gasoline on either a bonfire or charcoal, and you go to light it and it just flashes, that's usually it. And lightning is kind of the same way as a flash burn. Inhalation burns. We've already kind of talked about this and touched on this. Most deaths of fires because they've inhaled toxic gases or superheated gases, and they wind up having some sort of pulmonary injury. That's bad juju. It's bad. Infection for patients that they can have set up for infection. Hopefully you've done enough sterile dressings and bandaging, that can happen, so you'll protect them that way. Let's see what else. Carbon monoxide intoxication. Why they're putting this here, I don't know, but probably because it is a byproduct of combustion. So with that being said, carbon monoxide. Carbon monoxide loves hemoglobin, and it will attach to hemoglobin a lot faster than oxygen will, or our air will. So O2. So carbon monoxide has one carbon molecule and one oxygen molecule, and it attaches to the hemoglobin in the red blood cells a lot easier than O2 does. So that being said, it has a higher affinity for our hemoglobin. It's also harder to get off. Once it attaches, you actually have to use like some sort of barometric pressure chamber to actually force it to get off. So you can actually have, with carbon monoxide poisoning, pulse ox that's reading normal, within normal limits, or 100%, but they still look like ass. Meaning that they're not perfusing well because they're not able to carry oxygen very well because the carbon monoxide has bonded to the hemoglobin. So there's that part of it too. So hydrogen cyanide poisoning, central nervous system, that's also a byproduct of combustion, meaning that if they're in a fire and there's the byproducts of combustion, meaning that the smoke that's generated because of the fire is a byproduct, those are the things that you might encounter. Chemical burns, especially to the eyes, they are very, very vulnerable. One thing I want to talk to you about is the fact whether or not it's acidic or basic. I think some bases react violently to water, so if you actually go to flush it off, it's not going to do very well. It's actually going to make things a lot worse. So again, you need the MSDS sheets if they're there. Somebody that is very familiar with the chemical that can tell you that, like, this is how you treat this chemical and this is how you get it off. And if they do know that, hopefully they are on scene and already trying to help the person that's being affected. Stopping the burning process, remove all the chemical from the patient. Hopefully you can use water. If not, you'll have to brush and sweep it away. The brushing and sweeping away here they're using an emergency shower. They talk about different kinds of things: dry lime, copious amounts of water, sodium metals, you cover it with oil, hydrofluoric acid, or use calcium gluconate gel. Good luck finding that. Gasoline or diesel, remove with soap. That's going to get it. Hot tar, it's just cold water and try to actually stop the burning. So that's kind of the stuff that they figured you're going to come encounter with, but good luck with all that because those are all different and they're all different treatments. One of the things I do want to teach you, and I put this in, they're saying go ahead and hold the patient's eyelid open and actually take IV tubing, and I know you guys don't really know much about this, but take IV tubing to a saline bag and actually hold the patient's eye open and actually hold it and actually try to force flush that in. Don't have to do that. It's not always that bad. So if you do have chemical burns or chemical splash up into the eyes and you need to irrigate them, you can do this. You can use a saline bag. You lay their head back all the way into a supine position and you allow the water and stuff to run off out and away. It doesn't have to be completely supine, so you can maybe have to just do it and set up so it kind of runs down their cheeks a little bit, little slight elevation, so it's not running into their ears. But you can hook a nasal cannula to that and do the same thing. If you can tell, that's the prongs of the nasal cannula. And what they're doing is they're coming down and in. You got the bag here, the tubing attached to the nasal cannula, and now you're running, and the irrigation process is just, you allow this to flow into the eyes, and they can open and close their eyes and flush as they feel needed. And they actually can do that. And it's a lot simpler, a lot easier just to go ahead and do that. And that way they can close and open and flush, and they're doing it themselves, getting those eyes flushed. And if you run out of a 2000 saline bag, hook another one up and keep going. Electrical burns, you need to look for 2 points of injury. There's going to be an entrance and an exit wound. Entrance wound is usually not that bad. Entrance wound is even way worse. And you can actually have, just where it touches pinpoint, more damage under the skin that's actually showing more burn damage than you would actually have in an actual like thermal burn or any other type of burn. So usually the chemical burns, the thermal burns, radiation burns are going to burn outside in and progressively slow down. Electricity is a lot worse. It'll actually burn from one point and burn out and in. Another problem too is the fact of the path of the travel that it goes through. It's going to go in and go out. There's no question about it. It's going to touch somewhere and go back out. If it winds up crossing paths with the heart, you may actually stop the heart. You may cause dysrhythmias and slow the heart down, speed the heart up, make it so it's not, you have inadequate circulation, inadequate perfusion. So there's all sorts of issues that you could have with electrical burns. Cardiac and respiratory arrest from the electrical shock. We've already talked about that. Hypoperfusion and heart rate, that's a big thing. Radiation burns, alpha, beta, and gamma rays. I don't know how you can inhale radiation, but apparently you can. You can ingest a radioactive material or something that's radioactive and a direct exposure, meaning that it actually touches you. Alpha rays can be stopped by a piece of paper. Beta rays, you need like some metal to stop it, but it will go through a human being. The gamma rays are the worst of all. They will go through a human being, and you need like super metal, like lead, to stop them. So you can consider alpha's not that bad, and you can shield yourself from alpha with just simple clothing. If you're not with it, you're not too close. Beta rays, good luck. You need some sort of thin metal to do that, or some sort of thin protective suit. Gamma rays, you need some sort of thick lead suit. You're not getting close to that stuff. So that's the radiation. Radiation sickness that they're actually talking about, premature aging and death. You will probably need, if you have some sort of radiation or biologic exposure, something that is just causing radioactive contamination, you need a hazmat team, and you probably need a big one, because this is going to be bad juju. Local hazmat teams will probably have to call in like specialty teams and stuff like that. If you got radiation and radiation leakage, you need to make sure that these people that have been exposed can be in around you, that they're not exposing you to radiation. It's a big deal. So do the best you can with the patient, and do whatever the protocol says, whatever the special team says to do, and follow those rules. All right, guys, that should be it. It is. All right, see you guys later.